Hello and welcome to the fourth session of the Iowa Public Health Leadership Academy. To those of you with us for sessions 1, 2, and 3, thank you for joining us again. And thank you for taking the time to participate in the Academy. My name is Erin Tabor and I am the project coordinator of the Public Health Leadership Academy. And I just wanted to briefly thank all of you for the important work you're doing for your communities during this hectic and unprecedented time in public health. I also wanted to thank you for your flexibility regarding the Academy's schedule changes during this time and hope this format will be beneficial for you. This is the fourth of 6 sessions, and this session will cover health equity topics for boards of health and supervisors in Iowa. Betsy Ritchie, Director of Data Management and Health Equity at the Iowa Department of Public Health, will deliver the main content today. 3 local public health practitioners will also give examples related to health equity work in Iowa. These sessions are designed to build on content from previous sessions, so if you missed sessions 1, 2, or 3, you can view them by accessing the Iowa Public Health Leadership Academy website at iowaphla.com. Even though this session is being delivered in a unique format to accommodate your challenging schedules, we hope to meet again live for session 5. Session 5 is currently scheduled to take place on July 20th at 6 p.m. Before I turn it over to today's speakers, a few comments about the session. The resources mentioned in today's presentation and additional resources are all linked on the Academy website for your convenience. These are available under Curriculum and then Session 4. An evaluation has already been sent for you to complete after this session. Evaluation data will be used to inform the content for the next webinar in the series and for quality improvement on the series overall. We thank you in advance for your feedback. This evaluation will remain open until our next session on July 20th. Reminder emails will be sent as well. And please note that there are a number of action items we highlight during this presentation. However, as you all know, our local public health administrators or staff are inundated with COVID-19 response, so please consider holding action items until things ease up for your county. So now we can focus on the content for today's session. Today, we'll provide you with information regarding health equity related topics to public health in Iowa. If you could switch to the next slide. The learning objectives further define what you'll gain from this session and include explaining basic health equity concepts, identifying ways that data can be used to inform health disparities, discuss strategies to engage community voices, and utilize a policy systems and environment framework to address inequities. The competencies reflect skills that are desirable for individuals engaging in public health practice and management. The competencies provide a framework for workplace development to better improve the roles and responsibilities we play in enhancing the health of our communities. And the competencies for session 4 are listed right here. So now I'd like to turn the program over to our main speaker, Betsy Ritchie from the Iowa Department of Public Health. Thank you again for participating in the 4th session of the Iowa Public Health Leadership Academy.
Thank you so much. I'm honored to be here, and thank you so much for all of your flexibility. I know this is a very unprecedented time in public health, and it's a very exciting time, so thank you so much for watching this webinar. As Erin described, I'm going to provide an overview of health equity and then talk about some ways that it can be implemented within the public health structure. So first I want to start with just a general overview of health equity. And the definition that IDPH uses is that health equity is the attainment of the highest possible level of health for all people. It means achieving the environmental, social, economic, and other conditions in which all people have the opportunity to attain their highest possible level of health. That is a long and dense definition. But I think that the key piece of it is that achieving environmental, social, economic, and other conditions in which people have the opportunity to attain their highest possible level of health. So it's really thinking about what is the context that people live within and how do we create a context that promotes health. And so equity is a little bit different than equality. And I like this graphic from the Robert Wood Johnson Foundation to illustrate this difference. So equality is providing equal inputs to everyone. So in this graphic, everybody gets the same bike. But we can see that not everybody needs the same bike. It's not going to meet everybody's needs. Whereas equity kind of turns that concept on its head, and it provides the bike that each individual needs to go somewhere. And that's what we're really trying to do with equity, is that we're trying to provide the inputs and resources that each person in each community needs to achieve health. And that may look different from one community to another based on those environmental, social, economic, and other factors that influence people's health. One more way to look at it, again, is looking first at equality. And in this graphic, we see that each person gets the same size box to look at the baseball game. But we can see that one person doesn't necessarily need that help, and one person, that help isn't enough. So when we think about equity, it's really about redistributing those resources so it meets everybody's needs, so everybody gets to that same goal. And you know, in reality, we live in an unfair world. We don't have an even playing field. So there are some people that have way more than they need, and some people that are already 3 steps behind. So we need to think about where people are at and where they need to go to achieve their health. And ultimately, we want justice. We want everyone to be able to have healthy choices in their life. And that means removing unnecessary barriers, taking down those structural barriers that people have that are blocking them from optimal health. But health equity is also hard. It's full of jargon, and we're going to go through some of that jargon. And it can be uncomfortable because we're talking about disparities and inequities and, you know, things that are hard to talk about. And it's hard and it's messy. We're not always going to get it right, and there's going to be competing needs and competing priorities that come into play, and it's long term. It's not going to happen overnight. This is something that we will continue to have to work toward and strive toward. So first, I want to just take a step back and talk a little bit about health. What is health? The World Health Organization defines it as a complete state of social, psychological, and physical well-being, and not merely the absence of disease or infirmity. And that's a really nice string of words, but it's really vague. It's not operational. We can't take that and say, okay, now I know what I need to do to achieve health. But it's intentionally vague because everybody has a different perspective on what their health goals are. And so we have to think about that in public health, that there's multiple dimensions, and we're not just talking about physical health, but we need to be thinking about emotional and mental health and environmental health and intellectual health and all of these different pieces that come together to create health and wellness. And health is driven by lots of different factors as well. It's driven by our culture. It's driven by our lived experience, our environment, our social networks, our community resources, and policy, particularly us within public health, have a huge role to play in how we drive health through policy and through these structures that we're putting into place. And it's also important to remember that everyone has a culturally constructed view of health, that everybody has a different view of health. So we're not just talking about the communities that we serve having a different perspective than us, the public health practitioners, but it's everybody that's involved in creating health. It's providers, it's family, it's government. Us as the governmental public health system has our own view of what is optimal health. Payers, insurance companies often have a very different view of what is health, and they have a very powerful view because they get to determine what gets paid for and what doesn't. So it's just important to remember that when we're thinking about public health and we're thinking about improving population health, that people may be coming at this from different angles and have different perspectives on even what the goals are or what optimal health looks like. So I just want to do one last kind of little thought experiment to think through different ways to think about health. So here we have the World Health Organization definition again, but we then have to ask, okay, so what is health? What do we think of as health, especially as public health practitioners? What can we do? Is health insurance? That's very much how the Affordable Care Act constructs health. But we know within public health that just because you have health insurance doesn't mean that you are healthy. It doesn't even mean that you necessarily have access to healthcare. So that's probably not how we in public health would think about health. Is it access to providers? Is it being able to go to the doctor and get the preventive and treatment care that you need? But then we also have to ask, what kind of care? Everybody has different ideas about what's appropriate and what's not appropriate care for various scenarios, and that can vary within populations as well. Public health has a long history of addressing infectious disease, and we're doing it right now. And so in a lot of ways, our policies and structures are set up to address infectious disease within populations. But we know that infectious disease is not the only driver of health. And so we have to think about, how do we also support chronic disease and mental health? How does that play into this as well? And within public health, we also have to think about prevention. We want to not, solve the clinical problems that people are presenting with, but we want to prevent them from getting diseases in general. And so what are those preventive behaviors? Is it, drinking a green smoothie and going for a run? That's healthy behavior. That's something that public health promotes quite a bit, but that might not be what resonates with communities that we're working with. And health behaviors and healthy health behaviors vary over time as well. Here's an ad from the 1930s, excuse me, asking you to drink a stout beer every day for your health. That's probably not something that we at Public Health are going to recommend right now, but ideas around health change over time. If you do a Getty image search of health, the top picture that comes up is a white woman in her kitchen doing yoga while looking at her phone. I don't know. But again, this is probably not what we're striving for in public health either. And then if you go to the magazine rack at your grocery store, you're going to be faced with and presented with a very different view of health. And popular media also has views of health that they construct, that people consume. Great abs and minimal clothing, it appears. But I go through all of this to say everybody has a different perspective on what is health and different priorities as far as what is healthy and not healthy. And so we need to think about that when we're serving an entire population, be that within a community, within a county, within the state as a whole. And we have to understand that different people have different perspectives on health. One of the things that we talk about a lot within health equity work is social determinants of health. So these are the social factors, the conditions in which we live and experience life that influence our health outcomes. So these are things like the neighborhood that we live in, whether it's safe and walkable or not, health and health care, whether we have access to it and whether it's quality care or not, our social and community context. Do we have supportive social networks? Do we have communities with resources that we can access? Is education available? Do we have economic stability? Do communities have safe housing, and are they able to afford food and medicines and all of the other things that come along with economic stability? So within health equity, we try to work toward establishing policies and programs that positively influence all of these social factors that influence health to support changes in individual behavior. So basically, we're trying to create the context so people can make the healthy choice, that the healthy choice is a realistic choice and an easy choice. And we can see that these social determinants of health influence our health outcomes. So this is data from our Iowa Behavioral Risk Factor Surveillance System, or BRFIS. It's available on the Iowa Public Health Tracking Portal, which is produced by the Iowa Department of Public Health. And from this graph, you can see it's a question that we ask around people's general health. And then we break it down by income level. And so the higher number means more people in that category think that they're healthy. And we can see this very striking positive upward trend with income and health outcomes. So people who have more money think of themselves as healthier. They have more resources to achieve health. They have fewer stressors. They're able to have safe housing and all of these other things that we know go along with health. So we can see that income is a very, very important factor that influences people's ability to be healthy. And there's lots and lots of other social determinants of health. And I like this kind of infographic because it lays out a lot of them. You know, it's not just about economic stability, although that is very, very important. It's also about the neighborhoods that we live in, whether there's access to transportation and they're safe and they have playgrounds, whether people have health literacy or not, whether there's early childhood education supports. We know that that will influence a person's trajectory in life throughout the lifespan. Food, having access to healthy food options, not being food insecure, having a supportive social and community context, having community engagement, being in communities that are free from discrimination, and also having well-functioning healthcare systems, having not only health coverage, but provider availability, cultural and linguistic competency with our providers, and the quality of care as well. And all of these things come together to create the health outcomes that we within public health measure, like morbidity and mortality and life expectancy and all of the other things that we're trying to improve. So hang with me, got a couple more terms that I want to go through. We talk a lot about health inequities. So starting with health disparities, a health disparity is just a population-based difference in health outcomes. So it can be due to a multitude of factors. One of the most basic health disparities is that women get breast cancer at higher rates than men. Of course they do. It's a biological reality that women are at higher risk for breast cancer than men. That's a disparity, but it's not necessarily an inequity because it's not based in unequal socially determined circumstances. So a health inequity would be that example of income and health status, that there are socially determined inequitable circumstances that are creating poorer health for lower income communities than higher income communities. It's inequitable. And because these health inequities are socially determined, change is possible. Change might not be easy, but it's possible. And we also look at structural inequities. These are the structures or systems of society, such as financing, housing, transportation, education, social opportunities, all of these big structures that we exist within, that are structured in such a way that they benefit one population unfairly. Whether it's intended or not, one population still has greater benefit from those structures than others. And so we have to think about all of these different things, individual perspectives, constructions of health, policies and procedures and systems and institutions all come together to create the inequities and differences that we see in health outcomes among our communities. And we have to think about what we can do to mitigate those impacts and to ultimately change those systems and structures to make sure that everybody has equal health outcomes. And so all of these things that are kind of illustrated in this triangle come together to create these inequities that we're trying to prevent. And this is big and it is overwhelming, but it's important because we know that the structures are where we need to make change. It's not about individual choice creating population health. It's about the systems and environment that we exist within. And so we need to think about these big picture things to improve and create population-based health. I want to show just kind of one example of how this kind of all comes together. So within HIV care and within the HIV program at IDPH, we think about a continuum of care. So the goal of working with people who are HIV positive is to move them kind of through this continuum from when they're diagnosed, then we link them to care, then we hope that they stay retained in care and we work to keep them in care. We prescribe antiretroviral therapies and we hope that they take them routinely and appropriately. And ultimately the goal through this process is to become virally suppressed. And so in our programs, we measure where people are at. We use these for performance measures. We use them for quality management. These are kind of the key stages that we look at to make sure that we're doing the work that we need to be doing and should be doing to improve the lives of people who have HIV. But it's also important to think about what are the barriers that each individual person has and communities have to move from one stage to the next. And these can be large factors that are out of our control, but we need to do something to help support individuals that are experiencing these inequities and have a harder time getting through these stages to get to that end goal. You know, we want everybody to see over the fence at the baseball game. How do we get everybody to that virally suppressed place? And so that includes thinking about poverty and stigma and racism and incarceration and work and mental health and substance use and all of these other things that play into people's ability to move from diagnosis to viral suppression. So that's a lot. What can you do? First, don't use discomfort as an excuse to disengage. This is hard. It's big picture stuff. And we're not always going to get it right, and we're not always going to go in a clearer path, but we need to talk about it and we need to address it. And we need to learn when to listen and when to amplify, particularly those voices of communities that aren't traditionally heard or aren't traditionally invited to the table. And we also need to learn when to speak up and when to advocate for communities that are experiencing disparities. We need to educate ourselves. We need to engage our partners. This isn't just something that a health department can do. This is something that has to be addressed through multiple systems, through the entire community. So we need to work with others. We need to meaningfully engage with our partners to make movement on some of these really big picture things. And we need to take action to benefit others. We need to intervene, we need to advocate, we need to be an active bystander, and we need to create systems and advocate for systems that ensure equal outcomes for everyone. So how do we do this? How do we operationalize this at the Iowa Department of Public Health? Our challenge, our mission at IDPH is protecting and improving the health of Iowans. So our challenge is to create programs and policy and funding streams and all of the other work that we do that supports all people living in Iowa's communities across the state. And those communities look very different from one place to the next. And we have to ensure that we have the flexibility and the support to ensure that all of these different communities with different social determinants of health, experiencing different inequities, are able to all come to that same outcome of having optimal health. We need to create a structure that makes those desirable outcomes feasible and realistic for everyone. So that means different inputs for different communities. And we need to allow for communities flexibilities. One way that we're going to achieve health in community X might look very different from community Y. And we have to ensure community voice and agency. People within the communities know what problems they're facing, and they usually know the solutions to those problems as well. So we need to make sure that we're inviting those voices to the table and that we're giving them the space to make changes and advocate for themselves. So there's kind of three key strategies that we can use to further our equity work. The first is using data to identify disparities. So we should look at our data and break it down so we can identify those communities that are doing better and those that are doing worse. We need to engage communities to understand and address inequities. And we need to make systems, policy, and environmental change. We need to think about what role do we have in creating and changing that structure that people live within so they can be healthy. So the first thing that I wanted to talk about is using data to inform health equity. When we're looking at data, we want to identify disparities. We want to identify what parts of the population are getting to those health goals that we've set and what parts of the population are falling behind. Which parts of the population are being impacted more, what parts of the population have more risk, all of those things. So all of the outcomes that we look at, it's called data disaggregation. We break it down by race and ethnicity and age and income and education level and all of those different factors that we know influence health. And when we're looking at data, we ask what parts of the community are doing the best and what parts of the community are doing the worst. So here's just a basic example of COVID-19 disparities. So this is positive cases by race and ethnicity. So we can see that most positive cases are among white people in Iowa. And you would say, well, of course, because Iowa is a majority white state. But it's disproportionate. African Americans make up 12% of the COVID-19 cases that we see, but only 4% of Iowa's population. So there's a disparity. They're experiencing more cases than we would expect if everything were equal. Asian and Pacific Islanders have about 10% of the cases, and they make up 2.8% of our population. And if we move over and look at ethnicity, there's even more disproportionality. The Hispanic and Latino population is about 6% of Iowa's population, but 25% of all of our positive cases. So clearly, our data are telling us that there is something going on here, that there's communities that are having higher diagnoses, higher case rates than we would expect given their population. So then we have to start asking the question of why. And some of the things that float to the surface are that communities that are experiencing disproportional rates of COVID-19 diagnoses have poor living conditions. There are communities that are more likely to be critical workers and have less paid sick leave or no paid sick leave. There are also communities that we know are at risk for other underlying health conditions. Before COVID-19, we knew that those same communities had higher rates of asthma and diabetes and other conditions that cause more serious outcomes related to COVID-19. And these are also communities that face stigma and systemic inequities. And so we need to think about that. We need to think about what should we be doing for these populations to ensure that they are able to maintain health, particularly during a pandemic, and what are the factors that are influencing this disproportional rate that we see within our data. So at IDPH, as I mentioned, we try to break down data by various standards. We have data standards. They're available on our website. And we use standards for not only how to collect the data, but then how to analyze the data to make sure that we are able to consistently look at these various factors across all of our data sets at the department. So one more example that I wanted to show real quick is illicit drug use by age. And this is data from the National Survey on Drug Use and Health. And what I want to focus in on is the smaller graph to the right. And what this is showing is illicit drug use by age. So what we can see here from this graph is that people age 18 to 25 have highest rates of illicit drug use across the population. This is also the prime age for parenting. So we also have to think about what else is going on in these individuals' lives and how do we ensure that the entire household is healthy while, serious trauma is going on related to illicit drug use. This graph, again, I want to focus on the one to the right, shows illicit drug use by employment, and the higher brown bar is unemployed. So the key takeaway from this data is also that substance use is most common among those who are unemployed. It doesn't tell us why, it doesn't tell us how, but it tells us what. It tells us what parts of the population are most at risk for illicit drug use. It gives us that step one, but it doesn't give us everything. So we also have to think about what other types of data can we pull in to understand these types of scenarios. So we've been looking at quantitative data. Quantitative data is numbers, and it tells you the who, the what, the where, the when. It allows for statistical analyses and objective conclusions. But it doesn't get to that underlying why and how. And from a health equity perspective, that's what we really need to know to move forward to change the structure and environment and improve health among these populations. So we need to pull in qualitative data. We need to talk to communities. We need to engage communities, and this can be through interviews, focus groups, and a variety of other methods. And the qualitative data helps us to really understand the context around the issue. And it helps us to understand how social determinants of health impact health outcomes. So for example, with unemployment, we can tell from the data that people who are unemployed have higher rates of illicit substance use, but we can't tell why. We can't tell if substance use precedes unemployment, if unemployment precedes substance use. We don't know the context around it, and without knowing the context, we don't know what to do. Qualitative data can also identify issues that you may not have thought of. This goes all the way back to where we started, with everybody having a different perspective on health. And everybody's going to have a different perspective on all of these different health issues, and us as public health practitioners are not going to be able to identify all of them. We don't have that in-depth understanding of communities in a lot of cases, so we need to be able to go out and talk to them. And it helps us to create solutions to health inequities. So I just want to show kind of one quick example. This is qualitative data that IDPH collected related to economic vulnerability and substance use. And so if you read through these quotes, it gives you a much better understanding of that quantitative graph where people who are unemployed have higher rates of substance use. So this talks about how, and it also kind of gets at that age demographic too, where 18 to 25-year-olds are the highest risk age group, which is also prime parenting age. So these individuals are talking about their economic vulnerability as well as being a parent and using substances. So the first one, Bill, talks about how his work actually led him to substance use, which is counterintuitive, I think, to what a lot of people think. He says, I worked 79 hours, and it was like, on average, I worked 69 to 75 hours a week. I never got to see my family. I worked second shift. I never got to see them ever. So that was the part of the reason I used then, was because I could come home and stay up and visit with my partner all night. At least I'd get to see her. Then baby would get up and go to school in the morning, and I'd be able to get to see her, So he's making a rational decision to be more engaged with his family. And in this scenario, we can see a logic pattern to the substance use. The second one is talking about how substance use has caused her a barrier to employment. I want to go back to college, but regardless if I go back to college or not, like, my background is going to stop me from getting any job I want. And she goes on to talk about that more. So it helps you understand the context around the quantitative data, and it helps us get a lens and insight into what can be done from a public health perspective. So now I want to turn it over to Neela Johnson, who is with the Iowa Department of Public Health, to provide a local perspective on some work that she did within Johnson County.
So I am Dr. Neela Johnson. I am the Division Director for Health Promotion and Chronic Disease Prevention here at the Iowa Department of Public Health. I've been in this role for just over 6 months, and before I was at the State Health Department, I was a Community Health Manager at Johnson County Public Health. So one of the examples that I wanted to share with you today comes from my time in a local public health department. Before I get into some of these examples, I would like to share some of my definitions and thoughts around what I mean when we talk about health equity. So there, as Betsy has shared in her slides, there are multiple definitions of what we mean when we talk about the term of health equity. But I thought it would be important to share the kind of lens or view that I take to these definitions in order to see how that's applied to some of the projects that I've participated in. So when I think of health equity, I'm thinking it as a concept that addresses those social, those economic, and environmental barriers to producing positive health outcomes. And really the leading kind of agency around the concept of health equity is the Robert Wood Johnson Foundation. And their initial definition, as you can see on the slide here, was the sense of creating opportunity for everyone to have a fair and a just opportunity to be as healthy as possible. And I think it's a good definition, but oftentimes people get hung up on this concept of what does it mean to have a fair or a just opportunity at health. So more recently, I'd say in the past year and a half to 2 years, I've seen the Robert Wood Johnson Foundation use a definition stating that health equity is defined as increasing opportunities for everyone to live the healthiest life possible. And I really gravitate towards that definition because I find it to be a much more accessible definition or understanding of what we mean when we talk about health equity. So I'd also wanted to share that in 2017, the Iowa Department of Public Health created their own policy around health equity, and it had a number of different objectives, including things around data collection and the disaggregation of data in order to understand or be able to better key in and define on specific needs of populations. Also included things like our own kind of training around concepts of health equity and social determinants of health, so we know how to apply that to our public health programs and policy and decision making. It also had components around support for recruitment and having a diverse workforce. But included in that was a definition of health equity that was to the attainment of the highest possible level of health for all. So we see a similar theme there to the Robert Wood Johnson Foundation definition. In 2018, while I was at Johnson County Public Health, I also found it important for us to have our own understanding and definition of what we meant as a department when it came to health equity, and particularly thinking as we were wanting to support our staff's understanding and build their capacity around the concept of health equity and how it would apply to their work. It was important for us to have our own definition as a department. And what we utilized there was this understanding that various populations may be disparately impacted, and so we would strive to address those specific needs based upon those disparate impacts that we found within the population. So that gives you an understanding of how I understand and approach the concept of health equity and then apply that in the programs that I deal with. Next slide, please. So I wanted to share 2 examples of application of a health equity lens, both at the local level as well as at the state level. So the first would be, and these are both needs assessment examples. So the first would be from my time at Johnson County. As a community health manager, I was responsible for conducting the county's community health needs assessment process. So our goals around that were to look at both qualitative and quantitative data, as Betsy's slides were speaking to, and being able to identify what needs exist in the community and use those findings to really drive what our public health efforts would focus on for the next 5 years. So we had 2 main goals in the introduction of the needs assessment process, which we had lovingly termed Healthy JOCO. Our first goal was to have this broad community engagement as a part of our needs assessment process. And the second was to really incorporate a robust set of data collection methods. Our goals around broad community engagement, again, keeping health equity in mind, was the idea that in previous assessments, surveys were conducted that simply focused on convenient samples. We would find that the respondents were not representative of the breadth of the community, and the steering committee also was not representative of the breadth of the community and existed or consisted of your leaders of all your health systems or community partner organizations, social service organizations, all wonderful partners to be a part of a steering committee, but still only really focused on one point of view versus community members being able to provide direct input themselves. So with our goal of broad community engagement, we sought to have multiple ways in which we could gather information from community members. So we centered on 3 different data collections. The first was what we deemed the Healthy Joko Chats. So these were intercept surveys, and these were convenience samples, but we had a dual purpose of not only collecting information from community members themselves around their community health needs, but also wanting to engage community members to introduce them to the health department and the understanding that we were invested as a health department in having conversations with them about their needs. So these are short intercept surveys that we did across the summer, this past summer, throughout the county in different areas such as large community events. We were at the Iowa City Arts Festival. We were at Juneteenth. We were at Iowa City Pride. We were at the Hills 4th of July Festival. But also we were in targeted communities as well. So we held those Healthy Joko Chats at the Corville Food Pantry, at the Center for Workers' Justice, at the North Liberty Senior Meal Time at the Rec Center. So just being very mindful that we wanted to make sure we were out and across the county and being able to gather information, but also being mindful that we were talking to a breadth of community members and not just folks who would show up in downtown Iowa City. The second data collection effort that we did was a photo voice project, and we focused on conducting this photo voice project with a local youth agency. And the focus on the local youth agency was intentional because all of our other data collection efforts really focused on adults versus any kind of youth or input. But we also wanted to be mindful of working with the African American Serving Organization. So we worked with the Dream Center for this photo voice project. And again, being intentional about that because looking across the kind of disease rates and health behaviors, African American population in Johnson County is one of our most health disparate populations, but we had no specific programming specific to the African American population. So we looked at this opportunity as a way in which we could build a relationship with an African American serving organization. So over time, we could not only build trust with that community, but also have a resource to help inform us about what kind of initiatives would make sense and help support community health needs in the African American population for Johnson County. So the Photo Voice Project, again, we looked at this as a relationship building initiative, and we ended up meeting with the students there over 3 different sessions. The first, we came in and did what we called a public health fair. So we had different team members or staff members in the health department, one of our environmental health inspectors or specialists, one of our tobacco health educators, our health planner, our emergency preparedness planner, all come in and set up tables so that they could share the kind of work that they do with the students, to get them to not only learn about public health, but be excited about this is, the work that the public health department is doing on behalf of us and our community, but also to get them thinking about public health as, a potential career for them later down the road as well. The second session, we came in and talked about how you have resources or you have gaps in resources in your neighborhood and identified those through just a group facilitation and categorized them under people, places, and things. So we can walk through that process with them. And then we provided disposable cameras. So for the following week, they could go out in the community with their team leaders and then visually depict where those resources or where those gaps existed within their neighborhoods. And then in our last session, we came back having developed the film and talked through the pictures that they had taken as well. So again, it's a small data set as a larger part of the needs assessment process, but one that was intentional and meaningful in trying to build a relationship with the health district community in the county. And then our last and probably most significant undertaking was conducting the CASPR. So CASPR is a community assessment for preparedness and emergency response. This is a CDC scientifically valid rapid needs assessment, and it utilizes a randomized sample of households. So again, when we talk about those robust data set collections, we had our convenience samples through the intercept surveys, and then we sought to have a scientifically valid survey response tool for another data collection effort. And this would have allowed us to weight the data and be very significant in the types of responses that we'd be able to then say this is truly representative of what was occurring in the county. So we were able to, as a rapid needs assessment and preparedness, oftentimes this tool is deployed after a natural disaster like a hurricane or a flood to kind of see what are the immediate needs that you need in a community. But we adapted the tool to have a social determinants of health focus. And the tagline for Healthy JoCo was live, learn, work, and play, because those are the locations or areas in which health is found. So for our live section, we talked about social cohesion and the kind of connectedness people felt to their community or their neighborhood. The work section had employment and insurance questions. The play section had questions around what people do for their leisure activities, and we were really looking at where did we see, were people choosing more public focused leisure areas or something that you would have to pay or private type of leisure area. And so we could be able to inform decision makers on investment in parks or trails because they're highly utilized versus investment in, say, another mall or some other private focused facility. And then for the learn section, we administered a scientifically valid medical literacy tool. It was a word association game. And so our goal with that was to be able to identify what the health literacy rate was of various neighborhoods, and then that could help inform us in terms of our public health messaging. So we were able to deploy, utilizing a team of public health students from the University of Iowa College of Public Health. We were able to deploy the Casper survey over Iowa City, Coralville, and North Liberty in the summer. And that really was a wonderful experience in terms of having, boots on the ground. Again, what is the difference between people being able to respond to us if they're in a public setting, like we saw with the Intercept surveys, versus being on their doorstep and asking them to take a survey from us. And then subsequently, what we learned from that summer experience, we were able to then, that fall in September, deploy the Casper survey in the remaining 7 incorporated communities in the county. So that meant we were able to gather feedback and input from both our more urban or more populated areas, as well as our more rural or less populated areas of the county. So a much more representative survey collection than what had been done previously for needs assessments of the county. So again, along that broad community engagement, I think having a health equity lens really made us be thoughtful about who we were talking to and how we were choosing to approach gathering information from people. But also this idea of having that more robust set of data collection methods. So knowing we wanted to have both scientifically valid data that could be representative, as well as the convenience surveys, because they may be more accessible in order to talk to people and get a lot of people's response. But that qualitative part with the quantitative, I think, also strengthens kind of the worth of our assessment, because we're able to look at the data and know what our health statistics look like in the county, and at the same time have this really rich qualitative data set that helps tell the story behind what we're seeing in all of those health statistics. So the other example I wanted to share with you comes from the state, and this took place a few months before I actually started with the state health department, but I thought it was a similar kind of spirit and theme to what we wanted to do with Healthy JoCo. So the Iowa Department of Public Health, Title V, which is the Maternal and Child Health Program. So I am over the Health Promotion and Chronic Disease Prevention Division, and within the division we have the Bureau of Family Health, and they are in charge of our Title V Maternal and Child Health Program. So they are also required every 5 years to conduct a needs assessment, and that needs assessment helps identify what are the types of performance measures they should be considering based upon what they see are the changing needs in the maternal and child health populations of the state. So Title V has been around for 80 odd years, so they've been very used to doing this kind of needs assessment data collection, but they wanted to be mindful using that health equity lens of ensuring they were gathering input from, again, a breadth of participants within the Title V program. So one of the ways in which they sought to do that was through establishing a health equity advisory committee. So they identified community members who personally identified with some of the health disparate populations within our Title V programming population. And they utilized the Health Equity Advisory Committee to help develop the kinds of questions that they would ask in the assessment, to help recruit participants to the focus groups and to the interviews for the assessment, and to actually conduct some of those focus groups themselves as trusted community members in various communities across the state, which were targeted for the assessment. So again, this is an example of being able to support this more robust qualitative data collection because you're having those targeted focus groups, you're having those key informant interviews, and you're being mindful about the ways in which you should go about conducting them. So one of the things they did was ensure that they had translation available for community members who needed that. I want to say there was at least 8 different languages that were spoken amongst the focus groups that they held, and that included sign language for one of the participants for one of the key informant interviews. So I think overall between these examples, in terms of applying that health equity lens, is just being mindful about the approaches that you want to take, who's in your community, and being able to partner with folks who can help you gain the kind of information that you're seeking to gain in order to have a true sense of moving your programs and your policies forward.
All right. So the second piece that I want to talk about related to how do we operationalize health equity, how do we do health equity work, is to talk about participatory public health. This is to seek out voices that are typically unheard in decision making. So it's inviting those communities that are experiencing disparities to the table and listening to them and their perspectives as experts, because communities know their problems and they usually know their solutions as well. So we need to listen to them because they are experts in their own disparities. And we need to be able to empower them to define and express and analyze their disparities and their realities, and to tell us what needs to be done. And it's important also to note that it must be carried through all of the stages of public health, through planning, through assessment and planning, and implementation and evaluation. So it's not just going to a community and asking a bunch of questions and then going back to the health department and using that information to do a bunch of work. It's making sure that we allow communities to be partners with us in this work and work with them through all of the stages of public health and incorporate them into the entire public health life cycle. So I just kind of wanted to talk a little bit about what can be done within each of those public health life cycle stages to incorporate health equity. So within planning, one of the key things we need to do is to create mechanisms to meaningfully engage community partners. So we need to think about, how is your board, how is your health department engaging with the communities and voices that are typically unheard? And those voices are typically the ones that are also experiencing disparities. Is this being done during your China HIP process? And if so, how? And we should think not only about how planning for direct services, but also when we're thinking about policies and systems and environmental strategies that we're going to implement. We need to make sure that we're bringing community voices to the system. And here's a link just for a nice resource if you're interested in learning more. Plan for Health kind of combines traditional public planning and public health and has a lot of resources for thinking about health equity within those processes. And this is another toolbox that is available. In implementation, We need to think about how we're serving various communities. We need to ensure that communication materials are inclusive, that they're in the language that our communities speak, they're at the reading level that's appropriate, that they're provided through a mode that's easily consumable. You know, we in government like to put out relatively dense documents explaining our policies and procedures and everything else that we do. But that might not be the most consumable for all of our communities. So we need to think about what other ways can we communicate our work? Is it social media? Is it audio recordings? Is it radio ads? Is it interviews? Is it newspaper articles? What are the ways that we are actually able to reach our communities? And during the implementation process, we need to ask questions and create a dialogue. And we think about that PDCA cycle. And are you engaging community partners and community voices in all of that as we implement public health practices? And the easiest way to do this is to create a dialogue. It's to ask questions, because no one is an expert in all things, and no one is an expert in the experience of all cultures or all communities, but everyone can have a conversation. And if we start from that point of creating that dialogue and understanding that no one's an expert in everything and that we need all of our shared knowledge to move forward, we can create culturally competent and culturally appropriate and community appropriate public health. So here's another resource. This one is around active listening, which is just a great way to kind of create that shared dialogue. Another thing is to really think about the language that we're using and making sure that we're communicating inclusivity through the words that we're using. This includes using people first language and being aware of how language is used within our communities and how that can help to prioritize as well as stigmatize populations. It includes the graphics that we show and how we represent target or priority populations as well. And we need to make sure that we're avoiding stereotypes and gender-specific terms or excluding communities or reinforcing these power imbalances that have created disparities within our communities. In the evaluation stage, we need to think about how our activities impacted disparate groups and what the value was among those priority populations. So did they see this as a positive change? Did they see this as a valuable service? And we need to engage communities in assessing as well as sharing conclusions. So this is just another highlighted resource that's really helpful in incorporating health equity into our public health evaluations. And now I'd like to turn it over to Rima Afifi with the University of Iowa College of Public Health to talk a little bit about her work in engaging local perspectives.
Hello, everyone. I'm really excited to be here with you, and thank you for inviting me to share our experiences. I'm going to be talking about two specific projects where we've engaged in partnership with community in participatory planning. And I hope to answer the question, why is it important to have participatory planning to achieve the objectives of health equity, using those two projects as examples. So I wanted to start first with the idea of, what are some of the principles of participatory engagement or participatory planning in partnership with community. And I'm just going to go over a few. There's many principles, but I think the things that we always keep in mind are that in participatory planning, we often try to take an approach that's not only a deficit approach, which is in some ways the usual sort of the status quo for public health, and we try to find a problem and solve the problem. And of course, there's always issues that we want to improve in communities, but in that process, we often forget that communities are, full of really amazing potential and amazing assets and strengths. And so participatory planning allows for that uplifting of strength and assets that are involved in a community. And so that's sort of one part of it. The other part of participatory planning is really facilitating a collaborative, equitable partnership where everybody that's around the table is sharing power and also perceived to be an expert. So it removes this idea that there are only some people that are experts, and often those are either people that have university degrees or people that have positions of power. And participatory planning really tries to get rid of all of that sort of power structure that's inherent in society, to acknowledge that everybody has expertise and that our ability to be successful in community is only possible through acknowledging expertise and strengths of community members in the various aspects of their life, and particularly in their community. I don't know what will work in particular communities. I know in principle what are some of the components that might work in intervention, but every community is going to take that up differently. And so I think part of that is us being willing to play a role of facilitator rather than a role of an expert, and that makes a big difference. And I would urge that even if one is convinced that participatory planning is the right way to go, if we don't have the capacity, for whatever reason, environmental or otherwise, if we don't have the ability and capacity to actually implement participatory planning in this aspect of a shared decision making, listening to community, and actually implementing what they tell us from their expertise is the right way to go, we actually shouldn't engage in participatory planning, because that actually is worse. It does more harm. To look like we care about what community members tell us and then to ignore it is actually more harmful than not to ask them in the first place, in a sense. So sort of really to think about, are we able to do this, and can we remove our labels, I guess, and really engage in an authentic partnership where we understand and acknowledge expertise throughout. So I think I'll sort of focus on those as a background of really important principles in participatory planning, and now tell you a little bit about the two projects that we've engaged in as examples. So one of them is a project that the Prevention Research Center at the University of Iowa implemented in partnership with the city and community of Ottumwa. And that was a project that was focused on enhancing physical activity. It came out of a perception and data, not only a perception, data from the state that indicated that Ottumwa, that Iowa as a state has high rates of obesity as compared to other states in the United States. And when we looked at physical inactivity patterns, we found that there were some communities, and Ottumwa included, that had very high rates of inactivity. So like 25% of individuals in those communities saying they do absolutely no physical activity other than what's required in their sort of work-related space. And so the first thing that we did was actually reach out to the community of Ottumwa, and at that point to sort of structures in the community, so the local health department, the YMCA, the hospital systems, community organizations that are known to have impact in a particular community, and talk to them about, is this particular issue something of concern to you? Is it something that you're interested in working on? Is it something that we can work together to think about solutions for? And they were eager to work in partnership on this particular issue, because if there's no interest, then again, that's one of the reasons that participatory planning is important, in that if this is a problem that we as quote unquote public health practitioners, researchers, academics think is a problem because the data says it's a problem, but community members in those community, and by community members I mean both those with sort of formal roles in the health system and just people that live in those communities, don't perceive it as a problem, it really doesn't make sense to push forward until there is a perception of a problem. And that's one of the reasons that participatory planning is important. Is issue that we think might be a problem actually perceived to be a problem in that community. And this isn't right or wrong, right? I mean, even if the data says it's a problem, there could be many other problems in the community. And as we know, there are many issues, health issues that are of concern to communities. And there may be one that's more important at a particular point in time than others in a community for very many reasons that are absolutely justifiable, irrespective of what we are seeing sort of in the data. And that process of dialogue and building trust is really what gets us to ability in partnership to solve the issues that community members perceive as problems, and also to persuade each other about why something may or may not be an issue to deal with in the community, always acknowledging the strengths and assets within that community. So once we had identified in Ottumwa that physical activity was something that or inactivity was something that they were interested in working on, we actually then created a community advisory board that again had members on it from key organizations in the city of Ottumwa. And they were absolutely critical in thinking through what are the determinants of physical activity in that particular community. We were critical in bringing forth sort of what is the evidence base, the scientific peer-reviewed evidence base. And it's that combination of what specifically is the barrier or facilitator in a community from the community lived experience and okay, what do we see in the peer-reviewed literature? That combination together is what's going to create an intervention program that actually works in any particular community. And without the voice of lived experience from any community that comes from participatory planning, we really are not able to adapt interventions to be effective in any particular community. And part of the issue is a lot of the communities that we work in Iowa and other places, that's not where much of the evidence is coming from. So when we say evidence-based interventions, those are often tested in urban centers. They may be tested in, with different population groups. So they may or may not be applicable as implemented or as designed to the types of contexts that we're working in. And again, here we bring up the real critical importance of participatory planning. That project also went forth through engaging what we call physical activity leaders, so sort of lay people who lived in the Ottumwa community, were members of the community, who volunteered to lead physical activity sessions at every time of the day and night, and various kinds of activities that they were interested in leading. So from walking groups to yoga, to bicycling, to swimming. So a whole variety of activities that were led by people in the community. And the important part about that is that engages a lot of other community members, because the people that are leading these sessions are people that they know, that they trust, that are exactly like them, which also then engages a lot of other people. So those are sort of very small parts of how participatory engagement and planning with the Ottumwa community really, I think, went far in making sure that this process was effective. And in fact, the intervention was effective, and we were able to change the profile of the community of Ottumwa from sedentary to mild physical activity. So we now have an evidence-based intervention that we are now trying to upscale throughout the state of Iowa to be called Active Iowa. And there's a lot more details about how participatory planning was implemented throughout all the phases of Active Ottumwa, and it was a 5-year project. And those are available on the PRC website, and I'm sure we can provide the link to that. And also feel free to contact me related to that particular project. The second project that I wanted to share is the Congolese Health Partnership. And the Congolese Health Partnership is a project that's directed by Dr. Will Story at the Department of Community and Behavioral Health at the College of Public Health at the University of Iowa. And in fact, the story of the Congolese Partnership is a really interesting story, because Dr. Story came to academia from practice. So he was working on maternal and child health in international global health agencies. and for many, many years, and then came into academia from that. So he has sort of the practitioner experience that he brought into academia. And at the same time, Iowa City started to have a significant Congolese refugee community, and they're around maternal and child health. The family medicine practitioners, the OBGYNs in the university health system, were starting to see some challenges in communication, in understanding the cultural needs and norms around pregnancy and childbirth in the Congolese community. And actually, it was the health providers that reached out to Dr. Story, and asked for his support in trying to understand the cultural norms around pregnancy and childbirth in the Congolese community. Dr. Story had worked in Africa on many projects, and also to try to see what they needed to do differently to be able to serve the communities better. So from sort of a cultural humility perspective. Will got very interested in that project because of the work that he had done internationally, and started to reach out to the community because he's also a community participatory practitioner, and established the Congolese Health Partnership. And at that time, in the beginning of the partnership, there was actually 2 advisory boards. There was a health providers advisory board that were health providers from the University of Iowa hospitals and clinics that sort of first reached out to him and said, there's an issue here that we need to solve. And then he had a community advisory board that was Congolese refugees that were also sharing their experience in relation to maternal and child health and the interaction with the health system in Iowa, or in the United States for that matter. And at that time in the beginning, those 2 advisory boards couldn't be combined because there really wasn't enough trust between each other to be able to sit around a table and share ideas and experiences and concerns together. So there was 2 advisory boards, but Will was sort of the liaison between those 2 advisory boards, making sure that the connections were starting to be made, that the concerns and questions were shared, etc. And again, here, the reason that participatory planning was so important is there was, without understanding culture and context, there's a lot of presumptions that can be made about a particular community. So, why are they not understanding the US health system? Why are they not accepting some of the practices that we put in place, because they are evidence-based practices, right, in the healthcare system. And from the community perspective, there's a lot of, well, why are particular providers trying to force us to do something that we don't want to do? So on both sides, there's a lack of understanding of what the basic context is of the various parties, I guess. And what was really beautiful about the Congolese Health Partnership is that eventually there were a bunch of sessions that brought together the 2 community boards in the community. So in a place that was not perceived to be, I guess, owned or a place that is identified with the powerful, which would be, the University of Iowa healthcare system, but rather identified as a safe place by community members. So we used community-based organization space, places where the Congolese community congregated, and brought together the Congolese community and health providers or insurance. WIC came, and started to have a conversation where they presented information that they thought was important, and that there were interpreters at each of those sessions. So then there was an automatic translation from English into Lingala and French, and Swahili. Sorry, Lingala and Swahili. And then there was a big space, 2 large tables where people just sat around the table, people being some health providers and some Congolese community members, and there was an opportunity to dialogue, to ask questions, to understand, to get closer together in terms of what the concerns were. And what became very evident in that process of engagement is that So let's take WIC as an example. The community members were saying, well, we go down Walmart on these WIC aisles and we pick up things that are particularly in the WIC aisle. And then we get to checking out and they tell us that we're not eligible for that particular product. And we have it's very frustrating. We have no idea what we're eligible for and not eligible for. And the person from WIC, who was just so helpful, basically shared that there's an app that can be used to sort of help people understand which products are products that they can have, because the products that are relevant to a particular family are related to the number of children they have, whether or not they're pregnant, all sorts of things that identify, how much bread you get, or, what kind of products that you can have. Furthermore, the person from WIC said that they were very willing to actually meet a whole bunch of community members in particular places, let's say Walmart as an example, and go down the WIC aisles and actually answer any questions that community members had. So that's a very specific example of like, how do you bring people together? Because there's a lot of questions. The system is very difficult. This is not, the system in general, the healthcare system and all its pieces, it's complex and it's hard for people within the system to understand all the complexities. So for somebody outside the system that's new, and on top of that, new to the US culture, new to sort of Western medicine, that makes the complexity all the much harder. And if one doesn't understand the complexity of the system, then it makes it much harder to engage. Trust is lost very quickly, etc. Another example is that if you're pregnant and don't have insurance, there is emergency insurance that's basically provided to you for a particular amount of time, let's say 2 months of your pregnancy. So you're covered for 2 months and then you're covered for delivery, okay? So providers like those 2 months to be between 12 weeks and 24 weeks of pregnancy, because that's when they need to take all of the really important tests that sort of show whether or not a pregnancy is an at-risk pregnancy. Community members are thinking very differently, because community members are thinking of continuity. And if they do their 2 months between 12 and 24 weeks, then they perceive that they have no more continuity between 24 weeks and delivery, and that's scary to them. So they were actually pushing those 2 months to the last 2 months of pregnancy so that they would have continuity. And there was, again, this friction between what the community perceives and wants for very valid reasons and what the providers want for very valid reasons. And it wasn't until they started to communicate with each other and plan together that they understood each side and why each side was sort of preferring a particular 2-month period over another. And in the interaction between them, they were able to find solutions where, if you take the 12 to 24 months, we can give you information about providers that might be able to help you between that time and delivery. And again, it just made the process so much easier. Now, a year after the Congolese partnership started, there is now one community advisory board that includes both providers and community members, because trust was built to such an extent that they are now able to dialogue and understand sort of what the starting place is, and they all understand that their mission is the same mission. They all have a common mission to improve maternal and child health in the Congolese community. So again, just an example of how participatory planning and engaging community members is so important to success of health promotion and public health programs. I want to add one more thing about why these partnerships are important, and that is when a new challenge arises, a new challenge being what we're currently in, like COVID-19, having an already established community partnership makes things so much easier in terms of a quick response. So I can talk about either, but I'll focus on the Congolese Health Partnership. So when COVID-19 came up, there was a lot of information that was out there, a lot of evidence-based information, really important information about mitigation and prevention related to COVID-19. But it was usually very detailed, right? These mitigation measures are not very simple when you read the details of them. They were written in English often on pages and pages of text. And and the community, because they already had a link to the College of Public Health and to providers, were quick to say the information is not getting out to our community. And in fact, the way that we prefer to receive information is short videos. Instead of reading reams and reams of text, we would like to get it through short videos that are culturally tailored, that help us to understand these concepts. And there was a quick response where 3 short videos, and there has now subsequently been many more, but 3 short videos were made. What is COVID? Short, like 3 minutes, right? The second one was, what are some of the mitigation measures? And the third one was specific to Johnson County. So 2 of them are videos that can be used, across the nation, and one would have to be adapted to various places. So the third one is, where can you go to get more information in Johnson County, or to get a test, or to anything related to sort of mitigation measures related to Johnson County. Those videos were so popular that they have now been translated into 7 different languages. So way beyond the Congolese community to all the refugee and immigrant communities. And they were done very quickly. It was a very quick response. And the only way that we were able to do that so quickly is because there was already an established partnership, and not only an established partnership, a partnership that was built on trust, where they were able to say, we are not getting the information that we need right now, and this is what we think we need. So yeah, just to sort of an added benefit in new challenges of having participatory engagement and trust built between providers and community members. So I hope that that's given some concrete examples of how in Iowa, in very different communities, we've used participatory planning to be more effective, to build trust, and to engage in long-term relationships where really everybody's opportunities are uplifted, and health and well-being is promoted for everybody.
So finally, the third thing that we need to think about when creating health equity informed public health is policies, systems, and environment, and how these larger structures create the social determinants that influence health. So policies, systems, and environmental strategies help to ensure that the healthy choices are the easy choices for all community members. So these include changing laws and making sure that systems are supportive and easy to access, and shaping physical landscapes to make sure that people are able to make the healthy choice. And it also includes understanding the interrelated and interacting parts of society, and how a change in one area can affect and ripple across other parts. So just quickly, I wanted to go through kind of the 3 definitions related to policies, systems, and environments. So when we talk about policies, we're talking about those written statements. It can be at the organizational level. It can be a written course of action. That physical and observable environment, and it can also be built. So sidewalks and housing and all of those other things, as well as social factors that play into the environment in which people live. So one quick example I wanted to give related to policy, systems, and environment change is thinking about what your organizational policies are for communicating with people you provide services to. A few years ago at IDPH, we had a program that had a policy in place that they would send letters to inform people of some health risks. And, everybody's goal was to make sure that people were informed about their health risks and how to take care of themselves to be healthy. But the policy in place wasn't necessarily written from an equity perspective, because sending letters is not going to be the best communication mechanism for a lot of the population, for people who don't speak English well, who don't read well, who have transient housing, and other reasons that sending a letter isn't the most effective way to inform people. So we had to change our policy to think about what is that way that we can communicate with various populations and various individuals that's the most effective for them, so we can make sure that everybody is getting to the health goals that we had set out for them. So again, a policy, systems, and environment perspective takes in all of these bigger picture things, the institutions and the systems and the policies and the social determinants of health, and tries to understand how they come together to create health inequities, and then how we can change those things to ensure equity. So elements of a strong policy, systems, and environment strategy is that it's data-driven and it's grounded in community. So it's got those two components that we've already talked about. We look at our data, we identify where the disparities are, and we talk to the communities that we're serving and engage them within the entire PSE strategy. It should be ambitious, but we also need to make sure that it's feasible, and it needs to be financially feasible as well. It needs to be affordable. And its implementation and enforcement are clear and feasible, and it's legally feasible. So we need to have a really clear plan around what we're going to do and how we're going to create these changes, because these changes are often big and they can impact a lot of different areas. And it should address health disparities. It should address those things that we see in the data and those inequalities. And it should change expectations. So in the example that I provided about sending letters, it changed the expectations of staff to really, rather than kind of doing a rote process, to understand what our communities that we were serving actually needed. And it's one piece of a larger puzzle. It's not the end all be all, but it's something that can create change and can spur further change. So one action item that we're asking you to do is to review these elements with your board and determine how you can incorporate a PSE strategy within the work that you do. So I did want to give one more example of how policy, systems, and environment strategies have been implemented within COVID-19. And so this is from a non-governmental example. Eat Greater Des Moines is a nonprofit in central Iowa that works on food systems issues. And so within the COVID-19 response, it was very clear early on that we had two kind of competing and opposite issues. We had increased food insecurity. We had people who were not receiving paychecks, who had economic instability, and that was causing food insecurity at the household level. But we also had increased food supply because restaurants were was really actually to educate people around existing policy. The Good Samaritan laws exist that allow for food donation without legal risk. And they also worked with Lafredo Fresh Foods, which is a produce distributor in central Iowa, to help them change their organizational policies on food disposal. So organizationally, they were had policies to rescue and donate the food rather than disposing of it in a landfill. They looked at the systems factors. Transportation resources were identified in the communities to move the food from the distribution centers to the places where people needed the food. And the funding was redistributed and costs were shared to support this work. And they ended up partnering with low-income housing communities as well, because that's where the people were who needed the food. So they also partnered with landlords to create strategies to allow renters to have access to food. So the environment, the distribution occurred at low-income apartment complexes, and in most places, it was distributed in leasing offices or other common areas. The project also provided refrigerators because we're talking about produce, it needs to last longer, so they were able to provide some of the environmental needs to ensure that people could also access food. So I thought this was a nice example of using policies, systems, and environments to solve a problem that was identified within a community. But we see with the pandemic, there's many, many examples of PSE work that's going on. Some of the very first disaster proclamations that the governor put out way back in March changed regulations to allow online or delayed interaction. They allowed people to, go for an extended period of time without renewing a driver's license. They allowed people to transact government business online where it hadn't been allowed before. There's also been a lot of work of translation of guidance materials. So the Department of Human Rights in Iowa is providing a lot of support to translate the materials that are being put out to make sure that they're in the language that people need. And they're also providing audio recordings of a lot of it too for low literacy populations. We've seen work with employers of essential workers to change their business systems to improve health by using staggered shifts and health screenings and providing additional healthcare access, social distancing, and protective factors like facial coverings. And we can also see it within how, you know, stores and other places have placed social distancing markers and have redesigned spaces to ensure that people are staying a safe space apart. So there's a lot of examples within COVID-19 about how policy systems and environmental strategies have been taken to influence people's health and to help them make the healthy choice, and to help make the healthy choice be the easy choice. But now I'd like to turn it over to Abigail Chihak with the Dallas County Library Project and the Dallas County Health Department to talk about some of the work that they've done within policy systems and environment strategies to improve health.
Hello, and thank you for having me. Again, my name is Abigail Chihak, and I'm the Community Health Administrator at Dallas County Health Department. In Dallas County, we are the lucky participants in the Harnessing the Power of Iowa's Libraries project through the Iowa Department of Public Health. And this grant project has really allowed, is really designed to showcase how libraries in both urban and rural areas are able to become a bridge between the community and public health. Our goal as the rural pilot site at the Perry Public Library is to address the social determinants of health in a place where people are comfortable being. So to reduce those barriers that the public faces when trying to interface with our health department. So our project goals align with our county's community health needs assessment that was just completed this last year in 2019. And they focus on physical activity and nutrition. Specifically, fruit and vegetable consumption is our biggest goal. We knew from our needs assessment that 7.6% of our residents in our county were experiencing food insecurity. But we also knew from recent surveys that Perry would be a great place for additional nutrition outreach. 80% of respondents from Perry stated that nutrition education and services was something that they desired more of in their community. And 61% said that they believed that healthier food was needed to improve their health. Further, along with the desire to have more nutrition education in the community, we definitely saw the need within Perry. As the school district has the highest free and reduced lunch rate among all the schools within our county, with 74.4% of students participating. So the key components of our program target both the health knowledge and health beliefs of Perry residents, but also create those environmental changes that we've been talking about that are really necessary to help make it easier for residents to act on that newly acquired knowledge and beliefs. So as this is a partnership with the Library and Public Health, we started by implementing the National Network of Libraries of Medicine Reading Club materials. So we have book kits for book discussions on heart health, healthy aging, mental health, and family health. And those have all been purchased and put together and are ready for implementation. The goal of these book clubs is really to increase discussion around health topics and increase health literacy while reducing stigma associated with some of these topics like mental health. Additionally, we're working with Iowa State University Extension and Outreach as well as our local Hy-Vee dietitians to provide nutrition education classes. These classes are now scheduled for both youth and adults virtually throughout the summer. And further taste testing and giveaway events at local farmers market events earlier this year before everything shut down helped our community to really try out new fruits and vegetables that they may not have tasted before, to take some of them home and to try them in different ways, and to really learn about new healthy food options without those financial barriers. The environmental changes that we made are some of my favorite ones to talk about, and they're very exciting. On March 2nd, the Perry Food Recovery Program was launched within the library. And so through a partnership with E-Grader Des Moines, we were able to source an industrial-sized refrigerator, and it was donated and placed within the library lobby. Again, through their technical assistance, we were able to reach out to local grocers, and two of the local grocers in Perry agreed to participate in our program. So now 3 days a week, a library staff member collects food that the grocery store has had to pull from the shelf, but is still perfectly good for consumption, and brings all those fruits and vegetables back to the library and fills the fridge. Patrons are then able to come into the library anytime throughout the day during library hours and retrieve that food. The library is open over 50 hours a week, and so this program is really able to help people both supplement what they receive from the local food pantry and help those whose work schedules may not allow them to participate in other food assistance programs. This program is open to everyone within the community so as to reduce the stigma of participation. Our goal is not just to address food insecurity, but to address that overall fruit and vegetable consumption for the whole community. So placement in the library was really key in that strategy because all are welcome and encouraged in that place. Patrons of all income levels can come and grab a healthy snack as they visit the library after school. They can try something new that they see as they walk by, or they can just take what they need to feed their family for that week. Our goal is really to help, like I said, to feed those that are food insecure, but really to increase fruit and vegetable consumption across the board for everybody. So I'm happy to report that on our first week, 448 pounds of produce were recovered, all of which was claimed by residents within hours of being stocked on the fridge. The second week, over 500 pounds was recovered and distributed within the community. Unfortunately, due to library closures from COVID-19, the program was suspended on March 16th after 2 strong weeks, but we do plan to restart it as soon as the library again reopens to the public. Another large project, more environmental project that we're working on through this grant focuses more on physical activity. And so what we're doing is we're implementing a story walk throughout the parks in Perry. This project includes 30 mounted permanent posts, each on a 60 by 60 inch cement pad alongside the trail that goes through the park. Each post will be able to hold 2 pages of a children's book with pictures and a story that they can read as they walk through the park. So participants are encouraged to walk from page to page through the mile loop that is the park. The children's library staff will then change the story every couple of months and host a story time and guide people through the park each time that they change it to encourage participation. So far, we've got the cement laid and the posts ready, and so hopefully we'll be able to get our first book out and release it this month and kind of launch that program. So while COVID-19 has delayed some of our project strategies, we're still very excited to be able to bring both these educational programs, but also these environmental changes to Perry to help all of those residents, all of our residents, to easily access fresh produce and safe places for physical activity. Additionally, these tactics and strategies that we're using will be compiled with those at other libraries and to create a toolkit that libraries across the state can use to bring those public health strategies to all the people that we serve. Thank you.
Thank you so much, Abigail. So to conclude, we've covered a lot of ground. So I just kind of want to go through a couple of things to remember. This is really about what we're doing already and doing it better. Public health has focused on populations and the factors that influence population health. And so it's taking an additional lens, it's taking a more purposeful look at what we're already doing and trying to do it better. And it's hard. And there is no one size fits all. So a solution that works for one community may not work for another community. There's no golden ticket. So we have to do the hard work of figuring out what's going to work in different places and at different times. But I can tell you that we're on the right track by just having these conversations and by thinking about how do we create structures that ensure that everybody has equal opportunities for health is a step in the right direction. And it's important to remember that it will take a while to see the outcomes of changes made. We're talking about big picture issues, and so things aren't necessarily going to change overnight. That we're in this for the long haul, but we're in this together. And we at the state, you at counties, other organizations that you work with are working and should be working together to address the issues that create health inequities across the populations that we serve. So finally, here's kind of a list of resources from IDPH. As I mentioned previously, we have our Iowa Public Health Tracking Portal that provides data on a variety of health issues. And where possible, where the data is available, we break it down by those data standards that I mentioned. So you can see where communities are more or less impacted by various health issues. We also have a health equity website that provides some examples of the work that we do at IDPH. We have a health equity policy that's posted there, our data standards. The substance use project that I mentioned has a final report. And then we have an additional document with resources working toward health equity. And it really uses that public health program's life cycle framework to think about what are the different things that can be done throughout the public health life cycle to address inequities. So now I'm going to turn it over to Erin to close us out.
So thanks so much, Betsy. And before we wrap up today, we wanted to highlight the action items presented in the webinar. However, as I mentioned at the beginning, our local public health administrators and staff are obviously inundated with COVID-19 response. So again, just please consider holding these action items until things ease up for your county. So that being said, those action items that we want to highlight include asking your administrator how they're incorporating health equity into the agency's work, looking at data, including the COVID-19 data that everyone is getting from your county with a health equity frame. So asking questions like what populations are experiencing the most disparities in your community based on your China HIP, and how you are partnering with those communities. Another action item is to create mechanisms to meaningfully engage community partners. So how is your board engaging communities and voices that are typically unheard? And is this being done during your China HIP process? How so? Kind of like we mentioned above. Another action item is reviewing your policy, system, and environmental strategies. And do these things address health disparities? If not, how can you make sure your PSE strategies address health disparities? And finally, review those additional health equity resources that Betsy mentioned on the previous slide. And we have even more up on the Iowa Public Health Leadership Academy website as well. So just to wrap up, thank you once again to Betsy, Nalo, Rima, and Abigail for the excellent webinar, your collaboration, and your flexibility on this session. We hope everyone viewing this webinar found it both timely and informative. If there are any other questions on logistics or any of the content, please direct those questions to me at Erin-Taber, T-A-B-E-R, at uiowa.edu, and I will get them to the correct person. Again, thank you so much for joining us, and we look forward to being with all of you live, hopefully again in the near future.